To what extent can the provision of culturally appropriate healthcare services facilitate the needs and concerns of Black and minority ethnic communities? This presentation will highlight the importance of culturally appropriate healthcare services. Extracts from my interview with Eugene Ellis, the director of the Black African Asian Therapy Network, Barton, whilst highlighting key and relevant policy documents and academic texts that are relevant to this issue.
I used to look at Tumblr websites and used to see a lot of very skinny white girls on there, and I thought that was what I should look like. I was like, I need someone to talk to about this, who's going to help me.
Yeah. I don't think parents want their kid to have that stigma of a mental illness, because it is a scary thing. Sometimes you want to interpret it in different ways. Like, you can easily put yourself into a denial as to why someone is acting differently. Yeah. You might not want to put it down, especially in the Black community, you might not want to put it down to mental illness.
Fuck that, like, that's exactly what needs to change.
What does it mean to have a culturally appropriate healthcare service? Service providers may need to adapt to the needs of their clients. In conversations concerning the appropriateness of a service, cultural competence often comes into discussion. The European Psychiatry Journal published an article in 2015 stating that cultural competency represents good clinical practice, with the goal that all patients, especially those from minority groups, feel acknowledged and supported. This stresses the importance for the continued professional development of health practitioners, particularly when working in an increasingly diversified community. However, in an article on cultural competence in psychotherapy and counselling, Stanley Su poses the interesting question whether it is possible to really know the cultures of all groups in society. Can one ever be truly culturally competent? The Health and Care Professions Council have set out expectations of art therapists in their Standards of Proficiency document, ensuring the ability to practice lawfully, safely, and effectively. It states under 5.1 that art therapists need to understand the requirement to adapt practice to meet the needs of different groups and individuals. A membership survey conducted from the American Art Therapy Association in 2013 found that over 90% of respondents identified themselves as female and white. This is from Alkins and Diva 2013. This raises a serious concern, particularly when the IAPT Positive Practice Guide for BME communities states that people from some communities or faith groups may wish to only see a therapist from the same ethnic or religious background, and some may wish to only see a therapist of the same gender as themselves. Vicky Barber and Jean Campbell delve deeply into the idea of how colour comes to life when there are people of colour involved, either as therapists or as participants within art therapy. In the chapter Living Colour in Art Therapy, they highlight some stereotypes of black and white, which may have stuck in our psyches, such as black is bad and white is good. They were facilitators for an art therapy group named Women of Colour. There were pros and cons to the group. Some appreciated the freedom within the space, whilst others felt that any exclusive group provokes feelings of exclusion, envy, and anger. Stanley Su wanted to find out if ethnic matching was associated with positive outcomes. However, ethnic matching of therapists and clients has also raised the issue of segregation. Some used his research to justify segregation, although his findings were not intended for this purpose. Is the race and culture of your therapist really so important? And can the cultural background impact the progress of the therapeutic relationship? I interviewed Eugene Ellis, who trains as an integrative art psychotherapist and is now the director and founder of the Black, African and Asian Therapy Network based in North London. The organisation is the UK's largest independent organisation to specialise in working with Black, African, Asian and Caribbean clients. I think it's important to have Black, African and Asian psychotherapists and counsellors, or if you think it's important.
Yeah, I think it's important. I mean, the system I think that people go into needs to mirror them on some level, and colour of skin is a good start, and I think if it's seen as a totally white system, I think it's just going to make it harder for people to engage in it. Mm-hmm. So I don't necessarily think that people need to see someone from their own ethnicity. You know, that I don't ascribe to that at all, because sometimes that could be harder. Certainly for me, it was harder because when my first counsellor was a white woman and then a white man. So in a way, the transference doesn't really get evoked. Like if you're with a black man, for instance, then the father transference really comes alive more for me. So it's hard. It's hard work. It's harder work. So I'm not saying that's I'm not saying there should be that kind of matching, but no, I think there should be more people in the profession, and I think the more people in the profession, the more they will influence the counselling profession. So it's about the public face, and it's also about them influencing the system and influencing the theory and things like that.
Conclusively, it is suggested that having a professional or psychotherapist of a similar ethnic or religious background is not the basis to building a successful relationship with the client. However, by having more black and ethnic minority psychotherapists in the profession, this would benefit the progress of theory and practice and spark new debates and discussion. Earlier this year, Theresa May lectured at the Charity Commission in her speech on creating a shared society. She remarks on the everyday injustices we face as a society, such as the shorter life expectancy for those born poor, the harsher treatment of black people in the criminal justice system, and also the stigma and inadequate help for those with mental health conditions, all of which have been a source of discussion for many politicians. But Theresa May claims her mission to build a stronger, fairer Britain goes further. But what she fails to acknowledge are the barriers for specific communities who face additional barriers when accessing the National Health Services.
I'm 17 times more likely to be diagnosed with a serious mental health issue. That's scary. And I'm also 6 times more likely than a white man to be an inpatient or sectioned to a mental health hospital.
No Health Without Mental Health, the policy published in 2011, highlights the concern for a number of protected characteristics, some of which are age, gender reassignment, sex, religion or belief, and race. The government strives to tackle the inequality of service provision, hoping to close the equality gap for all people with protected characteristics. The document highlights under 6.12 that it will be extremely beneficial to deliver a truly personalised approach that identifies the specific needs of each individual. This is supported by the IAPT Positive Practice Guide that has focused on one of the named protected characteristics. They discuss the barriers that BME communities face, such as ethnicity, culture, language or faith. The document goes on to advise, under 3.2, that services should be maintained in a way suitable for BME communities that are also culturally responsive and language appropriate. There is an increased pressure for art therapists to demonstrate evidence-based practice to either continue services or demonstrate financial accountability. But with art therapy becoming less associated within the NHS and making moves to charitable organisations in the community, what is being done to allow creative therapies to become more accessible for hard-to-reach, vulnerable ethnic minority groups in the community?
Certainly psychology in particular have been trying to reach out to hard-to-reach black communities for many, many years and really failed. And it's really hard because there's lots of different dynamics to it. There's actually the internalized oppression, I think, within people, which stop them from reaching out early. And so they tend to wait for a long time till it gets worse, till their symptoms get really, really worse, and then they kind of meet the sharp end of the mental health system, and it's kind of secure unit and those kind of things. So that's sort of one aspect. The other aspect is a sort of historical one, really, where psychiatry and psychology has been, they haven't had a good history in terms of race and black people, and certainly through the eugenics movement and the way that psychology has kind of pathologized certain kinds of ways of being, means that there's a kind of there's a historical legacy really that the mental health system is kind of trying to work through, but they're not really directly addressing it. They're not labeling it as such. So it's problematic, how to then say I'm going to support you now. And the third thing is really the lack of thinking around these issues for therapy training, psychology training, psychiatry training. So it's a big problem, and even though we're a collection of black Asian therapists, I think we're still caught up within all of that. Obviously, we've got a bit more kudos. We can sort of, we can perhaps reach out a little bit more. But I think all those three dynamics are still there.
Undoubtedly, it will be difficult to engage with BME communities. The internalized oppression of ethnic minority groups has been an ongoing internal battle. Particularly in the therapeutic space, it may be difficult to explore negative feelings about themselves if they feel the need to defend a positive view of their blackness. Essentially, there needs to be more discussion and thinking around the issue of race and culture, particularly for psychotherapy and psychology training courses. There is some conflicting research regarding seeing a therapist of the same ethnic background, raising the issue of segregation. In the therapeutic space, seeing a therapist of the same cultural background can evoke the father-mother transference, which in turn can make the therapy more difficult depending on the person. There is also a cultural stigma within certain communities around mental health, which has prevented some from seeking help outside of their network. There are many policy documents that measure the effectiveness of healthcare services, and they conclude that services fall short of the standards. This has become more obvious with the growing demand from new service users who fall into the ethnic minority and previously did not use the services. It all comes down to the lack of training and understanding of the barriers that BME communities face. As a start, this could be addressed through CPD courses specifically on culturally responsive and language-appropriate services. Also, by coming together as a cohort and learning from one another, this will benefit the learning of professionals and trainees alike. The political and social shift of the UK post-Brexit, the impact on government mental health care legislation and funding, rising immigration over the last decade changing the blend of the British population, and due to the result of these shifts, we need to continue to develop our services so that it suits the needs of all clients and service users.